breaking news just a handful of days ago that Senator John McCain was diagnosed with brain cancer. And I know that that's been a conversation a lot of people are having, that they know somebody who had brain cancer, or, oh my gosh, what is this about? And what kind of surgery do you have to have and whatnot? So who better to join us on the show than Dr. Philip Stieg, founder and chair of the Weill Cornell Medical Brain and Spine Center and president of the Brain Tumor Foundation as well. And we could go on and on about Dr. Stieg's resume, and certainly this is his expertise. Dr. Stieg, I can imagine a lot of people were asking you about Senator McCain. So first of all, what kind of brain cancer was he diagnosed with?
He was diagnosed with what is the most common form of primary brain tumor, which is a tumor that originates in the brain that we see in the glial category. It's called a glioblastoma, and when we think about glial tumors, they're graded on a scale of 1 to 3, 3 being the worst, and his being a glioblastoma makes it a grade 3. So it's the most aggressive form of glial tumor that we have to deal with as neurosurgeons.
Yeah, and so when we hear that, and we kept hearing the word aggressive, what does that mean as far as surgery is concerned? What's typically what happens?
Well, typically what happens is once a diagnosis is made, then the protocol that we try to follow is an aggressive surgical resection followed by radiation therapy with concurrent chemotherapy. The extent of the resection is obviously dependent upon the size of the tumor and the location of the tumor. If the tumor is in what we refer to as eloquent brain, meaning the visual cortex, the speech cortex, or the motor cortex, then we're limited in regard to the extent of resection that we can perform, because this is a tumor that it's an infiltrative tumor, and it sends little tentacles into the normal brain, and there isn't a real boundary. You don't know when you've reached the end of it. So there's a limit to how much we can resect.
Is this typical what you see? Because as you know, when the senator went in, he was there to just remove a blood clot from above his left eye, and that's what they found.
It's not the most common presentation for this type of tumor. They are known to bleed, but more commonly they would present with either a seizure or with some neurologic deficit, again dependent upon where the tumor is located.
Yeah, and when you actually do the surgery, you and I have talked about the kinds of surgery that you can have. You talked about the surgery, of course, where often typically you're awake. In this kind of a surgery, would the person be awake?
Most probably he was not. I have not seen his scans, so I don't know exactly where the tumor is located. That being said, given the approach that they took, I suspect he was asleep, and they resected the tumor without him being awake. As we talked about earlier, the only times we really do awake surgery is when the tumor is located in those eloquent areas of the brain.
Yeah, and the reason you and I have talked about that before, the reason is, well, there's a couple factors. I mean, first of all, from the layman's terms, I think it's amazing that you do that, but it's because of speech, etc., so you can tell what's happening, right, by what you're doing back to the patient.
Right. The reason for doing the awake surgery is that we want to know exactly where we are in their brain, and while they're awake, we can test the function that we're worried about losing during the surgical procedure. So if the tumor were in his speech cortex or if it was in his motor cortex, we would most commonly do that awake.
Yeah, and it's interesting. One of the things the doctors said is that McCain, with this aggressive tumor, he was oriented, he had good balance, he had no headaches, no seizures, that kind of stuff. And the senator is someone who's had other malignant melanomas removed a couple of times, I guess like 3 of them. And he gets a lot of these kind of screenings and whatnot. And this was a significant operation, obviously, as you know. And, with the bone underneath the eyebrow had to be removed to do the procedure and then put back. Wow, I've never heard of that. That's typical? That's common?
It's It's a new approach that we use in neurosurgery. We commonly use the term minimal access or minimally invasive surgery. The reason for doing that is the recovery is faster, and he obviously had an exceptionally quick recovery. He was discharged from the hospital within 24 hours. So that's all beneficial for the patient. It also speaks to the fact, hopefully, again, I haven't seen the scans, that the tumor was caught early and that it was small and contained within the hemorrhagic or the bleeding area that they found.
Yeah, one of the things that I read, and also you would know this too, the mortality rate, but one of the things I read is there were some statistics from a study that was done back in 2009, and the study said that almost 10% of patients with that live maybe 5 years or longer, and this is from the American Brain Tumor Association. Again, Lena, looking at mortality rates, of course, who knows, but is that typical too as well?
Yeah, as I said earlier, this is the most aggressive type of tumor that we deal with. We don't use the word cancer because it doesn't spread to other parts of the body, but unfortunately it's in your brain, and as it continuously recurs, the average survival is 14 to 16 months overall. Again, having hopefully caught it early, and if he is a good responder. There are also a number of molecular markers that we use now, and those are predictors for long-term prognosis. So hopefully he has all the appropriate markers, and he will respond to the radiation and the chemotherapy.
Yeah, and you said this in the beginning, too, with the radiation and the chemotherapy. What's the typical course for that for most people? Because as we're discussing how aggressive it is.
Most people will go, we would wait after the surgery, wait several weeks for the wound to heal because radiation is hard on the scalp. And then it's 5 weeks of radiation with concurrent chemotherapy. And then subsequently the patient will get chemotherapy at regular intervals.
Yeah, you just did a presentation at the annual meeting of the European low-grade, is it glioma? Right,
glioma,
network,
yeah.
Glioma network, and in doing that, the focus there was the early detection. So, what's the early detection from the physician's point of view?
What we're trying to look at is to determine the cost effectiveness of getting MRI scans. And we do, not a full sequence of MRI, which can be expensive and time consuming, but a person could come in at periods in their life, or certainly people that are at high risk. And Senator McCain was at high risk, not necessarily for a glioblastoma, but for a metastatic melanoma, because they can frequently go to the brain. So you would get a quick scan that would help you detect early either metastases or a primary tumor. The major issue is everybody would like to have a scan, wouldn't you, just to make sure that you don't have any problem.
Yes.
But this is very much like mammography, the discussion that goes on with that. I mean, how cost effective is it? Can we afford to scan every citizen in the United States to rule out that they've got a brain tumor when the incidence, say, of glioblastomas is not really high. It's about 30,000 patients per year.
Yeah, glioblastoma. When we talk about that, and we talk about ages and whatnot. This across the board, you can see this he's 80 years old, but it could happen at any age, right?
Absolutely. We see them in 30-year-olds, we see them in 50-year-olds, and we see them in 80-year-olds. Some people think that we're seeing more of them. It is a slight uptick, but part of the issue is we're all living longer. And, 30 years ago, individuals died of heart disease and lung disease from too much cigarette smoke. And now we're living, and other things are creeping up.
Yeah. Wow. And this is too, and I looked this up to make sure I was right, Dr. Stieg, but this is the same kind of brain tumor that Senator Ted Kennedy had, if I recall.
It is. Hopefully the difference is that Senator Kennedy's tumor was in an eloquent part of his brain so that they couldn't get what is called gross total excision. And that, again, has an impact on long-term prognosis for a patient. Whereas Senator McCain's was in his frontal lobe. That is a more forgiving area. Hopefully they were able to be aggressive and get a complete resection.
Yeah, absolutely. Dr. Philip Stieg, founder and chair of the Weill Cornell Medical Brain and Spine Center. Thank you so much.
Thank you, Kate. Good to talk with you.